Mental health. It's a word we hear so often that it starts to lose its weight. But beneath the surface of familiar diagnoses lies a chilling depth, conditions that are misdiagnosed, misunderstood, or hidden altogether. This is the mental health iceberg, a descent into the human psyche, from what we know, to what we fear to name. Tier 1. Autism spectrum disorder is widely discussed today, yet still heavily misunderstood. It involves differences in social interaction, sensory processing, and communication, many associated only with severe developmental delays, but the spectrum is vast. Early diagnosis and support can improve quality of life, though stigma often leads to late intervention. The neurodiversity movement seeks to reframe autism not as a disorder, but a different way of experiencing the world. Depression. One of the most commonly diagnosed mental health issues, depression is far more than just sadness. It can manifest as numbness, hopelessness, or even physical pain. According to the WHO, it's the leading cause of disability worldwide. Causes range from genetics to trauma and environmental stress, with treatments including therapy, medication, and lifestyle changes. Its presence on the surface doesn't make it any less deadly. Anorexia nervosa is an eating disorder marked by extreme food restriction and an intense fear of weight gain. Often glamorized or minimized in media, it has one of the highest mortality rates among psychiatric disorders. Psychological trauma, perfectionism, and control issues are often underlying factors. Cognitive behavioral therapy and nutritional rehab are core treatments, but recovery can take years, and relapse is common. Sleep paralysis, a terrifying experience where the mind wakes up before the body. You lie frozen, unable to move or scream, often hallucinating dark figures or suffocating pressure. It's been linked to REM sleep disturbances, trauma, and even narcolepsy. Across cultures, it's been explained through folklore, demons, shadow people, or alien encounters. Though not dangerous physically, the psychological impact can be severe. Nightmare disorder. Not just bad dreams, this disorder involves recurring nightmares that disrupt sleep and cause significant distress. It's common in those with PTSD, anxiety, or a history of trauma. Nightmares often reflect unresolved fears, playing out over and over. Treatments include imagery rehearsal therapy or medication like prazosin, but for many, it feels like being haunted by their own mind. Insomnia. Difficulty falling or staying asleep can become a self-reinforcing cycle. Stress causes sleeplessness, and sleeplessness worsens stress. Long-term insomnia has been linked to depression, heart disease, and even early death. Cognitive behavioral therapy for insomnia, CBTI, is considered the gold standard, but millions still rely on over-the-counter sleep aids or melatonin. Specific phobias. From fear of spiders to fear of clowns, phobias are irrational, yet deeply real. They can trigger full-blown panic attacks and avoidance behaviors. Most develop in childhood and are rooted in traumatic associations or learned fears. Exposure therapy is the most effective treatment, but sufferers often mask their phobias, hiding them behind humor or avoidance. PTSD. Post-traumatic stress disorder alters the brain's threat response after extreme trauma. Flashbacks, hypervigilance, and emotional numbness are common symptoms. Military veterans, abuse survivors, and accident victims are all vulnerable. EMDR and trauma-focused CBT can help reprocess these memories, but untreated, PTSD can erode relationships, identity, and even sanity. Internet gaming disorder. Officially recognized in the ICD-11, this condition involves compulsive gaming that disrupts real life. It's most common among adolescents and young adults, especially in online multiplayer environments. Causes include escapism, social isolation, and dopamine-driven reward cycles. Treatments focus on behavioral interventions and digital detox, but it raises deeper questions about tech addiction in the modern world. Substance use disorder. More than just addiction, it's a rewiring of the brain's reward and control systems. Substances like alcohol, opioids, and stimulants hijack pleasure and coping mechanisms. Genetics, trauma, and mental health issues all play a role. Long-term recovery involves medical detox, therapy, and support systems like 12-step programs. But relapse is a constant threat, and stigma keeps many from seeking help. ADHD. Often brushed off as just being hyper, ADHD affects attention, impulse control, and executive functioning. it can look very different in children versus adults, and between genders. While genetics play a large role, environmental factors may influence symptom severity. Medication like stimulants and behavioral therapy are common treatments. Unmanaged ADHD can lead to academic, social, and emotional issues. Social anxiety. More than just shyness, social anxiety involves intense fear of judgment and humiliation. Everyday interactions, like ordering food or answering a question, can feel terrifying. It's rooted in overactive fear circuits and negative self-perception. CBT and exposure therapy are effective tools for rewiring those patterns, but many suffer silently, becoming experts at avoidance. Exploding head syndrome. Despite its dramatic name, it's harmless, yet deeply disturbing. Sufferers hear sudden, loud noises as they're falling asleep, bangs, crashes, even voices. It's a parasomnia thought to be linked to stress, sleep deprivation, or brainstem glitches. No clear treatment exists beyond reassurance and stress management. For some, it's a rare annoyance. For others, a nightly dread. Perfectionism. It sounds like a strength, but can become a psychological prison. Perfectionism often masks low self-worth, manifesting as chronic stress, burnout, and self-criticism. It's linked to anxiety, eating disorders, and even suicidal ideation. Therapy focuses on challenging distorted beliefs and building self-compassion. Left unchecked, perfectionism drives people to exhaustion in pursuit of an unattainable ideal. Generalized anxiety disorder, GAD. This isn't just worrying, it's constant, uncontrollable tension about everything. People with GAD anticipate disaster in even the most mundane tasks. Causes include genetics, trauma, and brain chemistry involving serotonin and GABA. CBT, SSRIs, and mindfulness are commonly used treatments. Left untreated, it wears down both mind and body. Dyslexia, a learning disorder that affects reading and language processing, not intelligence. Often diagnosed in childhood, it can impact academic confidence and self-esteem. It's neurological, with some genetic links. With proper support and accommodations, dyslexic individuals can thrive. But in traditional education systems, many slip through the cracks. Body dysmorphia. This disorder warps how someone perceives their physical appearance, fixating on flaws that may not even exist. It's related to obsessive-compulsive disorder and often coexists with eating disorders. Causes range from trauma to cultural pressure and serotonin imbalances. Treatment includes CBT and sometimes SSRIs. Left untreated, it can lead to isolation, self-harm, or unnecessary cosmetic procedures. Tier 2, the fog. Obsessive-compulsive disorder, OCD. OCD is characterized by persistent intrusive thoughts, obsessions, and repetitive behaviors, compulsions, performed to reduce anxiety. It is often trivialized as a preference for cleanliness or order, but the reality can be debilitating. Individuals may spend hours performing rituals to avoid perceived harm. The disorder is linked to dysfunction in serotonin regulation and abnormal activity in brain circuits related to decision-making. Treatment typically includes cognitive behavioral therapy, particularly exposure and response prevention, ERP, and SSRIs. Oppositional defiant disorder, ODD. ODD is diagnosed primarily in children and adolescents who exhibit a consistent pattern of defiance, irritability, and hostility toward authority figures. It is often seen as a behavioral problem but may stem from emotional regulation issues or environmental stressors. Children with ODD are at higher risk for developing conduct disorder or other mood disorders later in life. Parenting strategies, therapy, and sometimes medication are part of the treatment plan. Early intervention is crucial to prevent escalation. Transvestic disorder. This condition involves recurrent sexual arousal from cross-dressing, which causes significant distress or impairment in social or occupational functioning. It is distinct from gender identity or expression and is not considered a disorder unless it interferes with daily life. The classification remains controversial and is rarely diagnosed. Psychotherapy may be used when the behavior is tied to anxiety or shame. Its inclusion in diagnostic manuals is debated due to evolving understandings of gender and sexuality. Schizotypal personality disorder. Individuals with schizotypal personality disorder display eccentric behavior, social anxiety, and cognitive distortions such as magical thinking or paranoia. While related to schizophrenia spectrum disorders, it does not involve full psychotic breaks. The disorder is associated with both genetic and environmental risk factors, including childhood trauma. Treatment includes psychotherapy and sometimes low-dose antipsychotic medication. Social skills training may also help reduce isolation. Brief psychotic disorder. This rare condition involves the sudden onset of psychotic symptoms such as delusions, hallucinations, or disorganized speech, lasting less than a month. It often follows a significant stressor or trauma and resolves fully with treatment. It can be a precursor to more chronic conditions like schizophrenia if symptoms persist. Diagnosis is clinical and may require ruling out substance use or neurological issues. Antipsychotic medication and supportive therapy are commonly used during the episode. Borderline personality disorder, BPD. BPD is marked by emotional instability, intense fear of abandonment, and impulsive or self-destructive behavior. It is frequently misdiagnosed due to symptom overlap with mood and anxiety disorders. The condition is associated with a history of trauma, attachment issues, and difficulties with identity formation. Dialectical behavior therapy, DBT, is the most evidence-based treatment, focusing on emotional regulation and interpersonal skills. Recovery is possible, though often slow and non-linear. Gambling disorder. This disorder involves a persistent and recurring urge to gamble despite negative consequences in personal, financial, or social domains. It activates the brain's reward system similarly to substance addiction, particularly through dopamine release. The behavior often escalates over time, leading to cycles of loss and compulsion. Cognitive behavioral therapy and support groups like agoraphobia. Agoraphobia involves intense fear of situations where escape might be difficult, such as crowds, public transport, or open spaces. While often linked to panic disorder, it can also develop independently. Individuals may become housebound, avoiding situations that could trigger anxiety. Cognitive behavioral therapy and graded exposure are effective treatment methods. Medications like SSRIs are often used alongside therapy to manage symptoms. Antisocial personality disorder, ASPD. ASPD is marked by a pervasive disregard for the rights of others, deceitfulness, impulsivity, and lack of remorse. It is often associated with criminal behavior, but not all individuals with ASPD engage in illegal activities. Causes include genetic predisposition, early trauma, and poor parental attachment. Treatment outcomes are generally poor, but therapy focused on behavior modification may reduce harmful behaviors. It is more common in men and often overlaps with substance abuse. Pica. Pica is an eating disorder involving the persistent consumption of non-nutritive substances such as dirt, paper, or hair. It is most often seen in children, pregnant women, and individuals with developmental disabilities. Nutritional deficiencies and psychological factors are common underlying causes. Treatment includes addressing dietary needs and behavioral therapy. If untreated, pica can lead to serious health complications, including intestinal blockages and poisoning. Narcissistic personality disorder. This disorder is characterized by grandiosity, need for admiration, and lack of empathy, often masking deep insecurity. It can lead to unstable relationships, manipulation, and hypersensitivity to criticism. While commonly portrayed in popular culture, the clinical diagnosis requires significant impairment in functioning. It is believed to develop from a mix of genetic vulnerability and dysfunctional early environments. Treatment focuses on long-term psychotherapy. Tier 3, the deep. Schizophrenia. Schizophrenia is a chronic psychiatric disorder marked by delusions, hallucinations, disorganized thinking, and impaired social functioning. It affects about 1% of the population and typically emerges in late adolescence or early adulthood. While often portrayed violently in media, most individuals are more likely to be victims than perpetrators. The exact cause is unknown, but involves a combination of genetic, neurodevelopmentally, and environmental factors. Antipsychotic medications and psychosocial interventions form the basis of long-term treatment. Dissociative identity disorder, DID, involves the presence of two or more distinct identities or personality states, each with its own patterns of behavior and memory. It is commonly linked to severe and prolonged childhood trauma, particularly abuse. Controversy surrounds its diagnosis due to cultural factors and concerns of over-pathologizing dissociation. Neuroimaging studies have shown distinct brain activity patterns between identities. Treatment often includes trauma-focused psychotherapy aimed at integration or cooperation between parts. Oneirophrenia. Oneirophrenia is a dreamlike state of confusion and hallucination, often brought on by prolonged sensory deprivation or psychosis. It blurs the boundaries between waking life and dream states, with patients showing impaired reality testing. Historically, it was proposed as a subtype of schizophrenia but is no longer officially classified. It may appear in extreme stress conditions, including sleep deprivation or drug-induced psychosis. Management focuses on stabilizing the underlying cause and ensuring sensory reintegration. Erotomania, also known as de Clerambault syndrome. Erotomania is the delusional belief that someone, often of higher social status or a stranger, is in love with the individual. The condition is rare and typically presents in isolation or as part of a broader psychotic disorder. It can lead to obsessive behavior, stalking, or repeated attempts to contact the perceived admirer. Causes may include underlying schizophrenia, bipolar disorder, or head trauma. Antipsychotic medication and psychotherapy are standard interventions. Parental alienation. Parental alienation refers to a child's unwarranted rejection of one parent due to manipulation or influence by the other parent, often in the context of custody disputes. It is not recognized as a formal psychiatric diagnosis, but its psychological consequences can be profound. Children may internalize distorted beliefs, leading to long-term relational and emotional dysfunction. Critics argue the term is sometimes misused in legal settings to undermine abuse claims. Therapeutic reunification and family therapy are recommended when safely applicable. Factitious disorder, Munchausen syndrome. This disorder involves deliberately falsifying or inducing illness in oneself or another for psychological gain, often to assume the sick role. It is distinct from malingering, where the goal is external reward. Here, the motivation is internal and often unconscious. Some cases, especially involving caregivers inducing illness in children, are severe and can be life-threatening. The cause is often linked to early trauma, personality disorders, or a need for control. Treatment is complex and requires careful psychiatric and medical coordination. Dependent personality disorder. This personality disorder is characterized by excessive reliance on others for emotional and decision-making support, even in situations where independence is appropriate. Individuals may fear abandonment to the extent that they tolerate mistreatment or suppress personal needs. It is believed to arise from early experiences of neglect, overprotection, or attachment disruptions. Long-term psychotherapy helps build autonomy and assertiveness. Progress is gradual, and setbacks often occur under stress. Rumination disorder. Rumination disorder involves repeated regurgitation and rechewing of food, not due to a medical condition or intentional vomiting. It typically develops in infants or individuals with developmental delays but can occur in adolescents and adults under stress. The behavior is often automatic and may be soothing or self-stimulating. Complications include malnutrition, weight loss, and dental erosion. Treatment includes behavioral interventions and nutritional support. Bulimia nervosa. Bulimia is characterized by cycles of binge eating followed by compensatory behaviors such as vomiting, excessive exercise, or fasting. Unlike anorexia, individuals with bulimia often maintain a normal weight, which can delay diagnosis. It stems from issues of control, self-image, and emotional regulation, often co-occurring with depression or anxiety. The cycle becomes neurologically reinforced through reward pathways. Cognitive behavioral therapy and nutritional rehabilitation are essential for recovery. Tourette syndrome. Tourette syndrome involves repetitive motor and vocal tics, which can range from mild to severely disruptive. Onset occurs in childhood and may decrease with age, though some cases persist into adulthood. It is thought to involve dysfunction in the basal ganglia and dopamine systems. Many individuals also experience co-occurring conditions like ADHD or OCD. Behavioral therapy, medication, and in severe cases, deep brain stimulation are used to manage symptoms. Bipolar disorder. Bipolar disorder causes dramatic shifts between depressive lows and manic or hypermanic highs, affecting mood, energy, and activity levels. The condition has strong genetic links and involves irregularities in brain structure and neurochemical signaling. Manic episodes may include risky behavior, grandiosity, and decreased need for sleep, while depressive phases mirror major depression. Lithium remains the most effective mood stabilizer, alongside other medications and psychotherapy. Proper diagnosis is essential, as mistaking it for depression can worsen the condition. Kleptomania. Kleptomania is a rare impulse control disorder marked by a compulsion to steal items not needed for personal use or value. The act often relieves tension or anxiety but leads to guilt afterward. It is distinct from theft driven by necessity or antisocial behavior. Underlying causes may include serotonin dysregulation or coexisting psychiatric conditions. Treatment includes behavioral therapy, antidepressants, and addressing any comorbid disorders. Hallucinogen persisting perception disorder, HPPD. HPPD involves recurring perceptual disturbances, such as visual trails or flashes, long after hallucinogenic drug use has ended. Symptoms may resemble a permanent flashback and can interfere with daily functioning. It is more common after use of LSD, psilocybin, or MDMA, though not all users are affected. The underlying mechanism is not well understood, but involves persistent alterations in visual processing. Benzodiazepines and antiepileptic drugs are sometimes used, though there is no guaranteed cure. Tier 4, or the abyss. Reduplicative paramnesia. This rare delusional misidentification syndrome causes a person to believe that a place or location has been duplicated, existing simultaneously in two or more locations. It often follows brain damage, particularly to the frontal lobes or right hemisphere, and is most commonly observed in patients with dementia or after trauma. The condition challenges basic spatial awareness and memory integration. It is sometimes linked to other delusions like Capgras or Fregeli syndrome. There is no specific cure, but cognitive rehabilitation and antipsychotics may help manage symptoms. Diogenes syndrome. Named after the ancient philosopher known for extreme self-sufficiency, Diogenes syndrome involves severe self-neglect, social withdrawal, hoarding, and poor hygiene. It is usually seen in elderly individuals and is often associated with dementia or frontal lobe dysfunction. The syndrome can go unnoticed for years, as individuals isolate themselves from society. Its causes may include trauma, psychiatric illness, or neurological decline. Treatment is difficult and often requires intensive social and medical intervention, sometimes under legal compulsion. Stendhal syndrome. This psychosomatic condition is triggered by exposure to overwhelming beauty, particularly in art or nature, resulting in dizziness, fainting, rapid heartbeat, and even hallucinations. It was named after the French author Stendhal, who first described the symptoms after visiting Florence. Though debated in clinical circles, it has been reported multiple times by tourists and museum visitors. The condition seems to reflect the brain's inability to process emotional intensity. Symptoms are usually temporary and treated with rest and, in rare cases, psychiatric support. Fregeli syndrome. Fregeli syndrome is a rare delusional disorder where the sufferer believes that different people are, in fact, a single person who changes appearance or is in disguise. It often arises in schizophrenia or after brain trauma, particularly in areas linked to facial recognition. This distortion of identity perception causes extreme paranoia and distrust. It is considered part of the misidentification syndromes, alongside Capgras and reduplicative paramnesia. Antipsychotics and structured reality testing through therapy are key components of treatment. Aboulamania. Aboulamania is characterized by extreme indecisiveness and an inability to make even simple decisions without excessive anxiety or distress. Though not formally listed in major diagnostic manuals, it is considered a potential subtype of anxiety or obsessive-compulsive spectrum disorders. The individual may obsess over minor choices, fearing permanent consequences or disapproval. This can lead to social withdrawal, dependency, and depression. Cognitive behavioral therapy and decision training exercises are often used in treatment. Capgras syndrome. Capgras syndrome involves the persistent belief that a loved one has been replaced by an identical imposter. It is typically linked to neurodegenerative diseases, brain injury, or schizophrenia. The condition reflects a disconnect between facial recognition and emotional familiarity. Patients can recognize a face, but the emotional connection is absent, leading to a false conclusion. Capgras is both unsettling and dangerous, as it can erode trust and trigger aggression. Antipsychotics, therapy, and caregiver education are used to manage the condition. Shaka-Wilbrand syndrome. This rare neuropsychological condition results in the inability to mentally visualize or dream, often after damage to the occipital lobe. Patients report the sudden loss of visual imagery, even when awake. Though memory and cognition remain intact, their inner world becomes flat and imageless. It's often accompanied by other visual impairments, and recovery depends on the extent of the brain damage. There is no standardized treatment, but neurorehabilitation may restore some function over time. Boanthropy. Boanthropy is a psychological disorder in which a person believes they are a cow or ox, behaving accordingly by walking on all fours and grazing. While extremely rare, cases have been documented historically and interpreted through both psychiatric and cultural lenses. It may be associated with psychosis, schizophrenia, or intense hypnotic suggestion. Historical references date back to Babylonian times, with one of the most famous examples being King Nebuchadnezzar in the Bible. Treatment involves antipsychotic medication and intensive therapy. Narcolepsy. Narcolepsy is a neurological disorder characterized by uncontrollable episodes of sleep during the day, often accompanied by cataplexy, sudden muscle weakness triggered by emotion. The condition stems from a deficiency in hypocretin, a brain chemical responsible for regulating wakefulness. It significantly disrupts daily life, often mistaken for laziness or lack of discipline. Though lifelong, narcolepsy can be managed with stimulant medication, scheduled naps, and sleep hygiene. It exists at the crossroads of neurology and sleep science, challenging what we know about consciousness itself. Tier 5, the distorted. Shared psychotic disorder, folia dux. This condition occurs when a delusional belief is transmitted from one individual to another, usually between closely related people, siblings, partners, or parent and child. The primary individual suffers from a psychotic disorder, and the secondary adopts their delusions due to isolation and emotional dependence. Cases often dissolve when the individuals are separated, though both may require treatment. It's a chilling reminder of how belief, not just biology, can shape madness. Antipsychotics and individual psychotherapy are essential for recovery. Truman Syndrome. Truman Syndrome is an unofficial but increasingly recognized delusion where the sufferer believes their entire life is a staged reality show. Inspired by the Truman Show film, this belief involves intense paranoia, with individuals convinced that everyone around them is an actor and their environment is fabricated. It reflects a breakdown of trust in reality and a hyper-awareness of surveillance culture. It's typically seen as part of schizophrenia or delusional disorders. Treatment focuses on antipsychotic medication and cognitive therapy to re-establish trust in the real. Clinical lycanthropy. A rare psychiatric condition in which a person believes they are transforming, or have transformed, into an animal, most often a wolf. The condition is historically tied to folklore and werewolf legends, but presents today in delusional forms of schizophrenia or mood disorders. Patients may growl, crawl, or behave animalistically. Neurological studies suggest abnormal activity in brain areas responsible for body image and identity. Treatment is rooted in antipsychotics and addressing the underlying psychiatric condition. Alien hand syndrome. This neurological disorder causes a person's hand to act on its own, often performing actions the person cannot control. It is usually the result of brain surgery, stroke, or trauma affecting the corpus callosum or frontal lobes. Individuals describe their limb as having a will of its own, sometimes even resisting the person's intended actions. Though rare, the phenomenon is well documented and profoundly disturbing for those affected. There is no cure, but visual feedback and occupational therapy can help patients regain some control. Hysterical blindness, conversion disorder, also known as functional vision loss. Hysterical blindness involves the loss of vision without any detectable damage to the visual system. It's a type of conversion disorder, where psychological distress is converted into physical symptoms. Triggers often include extreme trauma or prolonged anxiety. Despite intact eyes and optic nerves, the brain shuts off visual perception. Treatment involves psychotherapy, reassurance, and addressing the underlying emotional conflict. Tier 6, the broken core. Kluver-Bucy syndrome. This rare neurological condition follows damage to the temporal lobes, particularly the amygdala, resulting in dramatic behavioral changes, hypersexuality, compulsion to put objects in the mouth, emotional blunting, and visual agnosia. Originally observed in monkeys, it has been documented in humans after traumatic brain injury, herpes encephalitis, or degenerative disease. The syndrome renders once recognizable behaviors foreign, primal, and uncontrollable. It's an eerie reduction of humanity into raw instinct. Treatment is supportive, often involving antipsychotics and behavioral therapies. Apotemnophilia, body integrity identity disorder. Apotemnophilia is the intense desire to amputate a healthy limb, stemming from a mismatch between one's mental body map and physical form. Individuals often feel that the limb doesn't belong to them, sometimes resulting in self-harm to force amputation. It is not a psychosis but rather a body identity disorder, possibly linked to right parietal lobe dysfunction. Sufferers report relief and completion after amputation. Treatment is ethically complex. Some advocate psychotherapy and brain-based research, while others controversially support surgical intervention. Coated delusion, walking corpse syndrome. Perhaps the most haunting psychiatric condition, coated delusion, is the belief that one is dead, does not exist, or has lost internal organs or blood. Patients may stop eating, socializing, or even moving, fully convinced they are a corpse. It often appears in severe depression or psychosis and is associated with dysfunction in areas related to emotion and self-awareness. Some individuals request to be buried alive or reside in morgues. Antidepressants, antipsychotics, and electroconvulsive therapy have shown success in treatment. Tier 7, the unspoken. Pyrophilia. Pyrophilia is a rare paraphilic disorder where an individual derives sexual gratification from fire or the act of setting fires. It is distinct from pyromania, which involves an impulse to start fires without sexual arousal. The condition may stem from early traumatic associations or developmental disruptions in sexual identity. Pyrophilia is almost never self-reported and often comes to light only after criminal behavior. Treatment is unclear, but psychotherapy and behavioral interventions are used when identified. Autophagia. Autophagia involves the compulsion to bite, chew, or consume parts of one's own body, fingers, arms, or even lips. It's not driven by psychosis in all cases but often tied to severe anxiety, psychotic breaks, or neurological conditions. Some sufferers report relief from tension or emotional numbness through the act. Cases can become life-threatening and often require hospitalization. Treatment includes antipsychotics, behavioral therapy, and protective restraints in acute phases. Folie en famille. An extreme extension of shared psychosis, Folie en famille occurs when an entire family or close-knit group adopts a shared delusion. Unlike folia ducts, the belief spreads like infection, feeding on isolation and emotional dependency. Historical cases include entire households believing they were pursued by secret agencies or chosen by divine forces. The phenomenon reveals how belief, when reinforced by closed systems, can override rationality in groups. Separation, therapy, and reintegration into broader social environments are essential. And that's the end of the iceberg, for now. Mental health runs deeper than most of us realize. Some things are easy to spot, others stay buried, but they're all real and they all matter. Thanks for listening. If you found this interesting, consider subscribing. There's always more to explore beneath the surface.